Perfect. Well, thank you all so much for being here. My name is Willa Bluestone. I'm the Director of Policy and Workforce Strategies at Ohio Life Sciences. We're the state's trade association for everything from pharma to food science. So again, just thank you all for being here. Looking forward to a great presentation, great discussion. I'd like to start by thanking Eli Lilly, first off, for sponsoring this fantastic event, particularly Tracy Sims, from whom you'll hear in just a few minutes, and Ed Sagabiel for his endless support and guidance on this. We'd also like to thank the Buckeye Institute for their proclivity in this topic, also for their willingness to speak today on this really important issue. So today we'll be discussing obesity in the workforce. You'll hear from Ray Hederman from the Buckeye Institute. He is the Executive Director of Economic Research, the center there, and the VP of Policy. And then you'll hear from Meredith Craig, very thankful to have her here from the Ohio Chamber of Commerce. She's the Director of Healthcare Policy there, and prior to that was at the Ohio Department of Insurance, so very well-versed in this topic. Lastly, as I mentioned, you'll hear from Tracy Sims, the Executive Director of Corporate Affairs at Eli Lilly. So obesity, as we all know, can be a very sensitive topic, and today's society especially, but I would encourage all of you to approach today with a very open mind for the entirety of the presentation for every one of our speakers. So, I mean, for instance, just up until a few years ago, we viewed addiction as a choice, but now we're understanding that it's a medical condition that requires compassionate care and medical intervention. So, again, just please approach today with an open mind, and with that, please welcome Ray Hederman from the Buckeye Institute.
Great. Thank you all very much for coming in early on a busy day. So excited to talk about this topic. So why do we think this topic is important? And this is the first graph, and it looks at labor force participation in Ohio. And labor force participation rate is simply asked the question is, if you're 16 or over, are you in the labor force? And that means, do you have a job or are you looking for work? If you're employed or unemployed, you're in the labor force. That means you're available to work. If you're not, you're out of the labor force. And as you can see for the graph, we've been on a downward slide, and yes, you can obviously see where the COVID pandemic hit and cratered. The problem this shows is that when you have fewer people looking for work, that means there's fewer able bodies able to work. And for so long in the state of Ohio, we've talked about we need to find and create more jobs. What we're starting to switch into a situation is we need to find workers because we have the jobs. Very quick context on the current state of the Ohio labor market. We have an unemployment rate of 3.7%, our lowest ever since they started keeping track in the 1970s. Our labor force participation rate is 61.8%, still trailing the national average. We have averaged 340,000 job openings for the first quarter. Ohio was one of the few states actually to increase the number of job openings in the month of March, trailing only Florida among states where the job numbers increased. We have a record number of job openings with small businesses at a record high, saying that they are looking for workers, but they can't find them. Last month in May, the national NFIB survey said 90% of small businesses had job openings, but they could not find qualified employees. Same data has come across from manufacturers saying we have job openings, we cannot find people to fill them. Obesity in Ohio. So starting to look at some bad news. So about 38%, almost 40% of Ohioans suffer from obesity. You'll notice this number is higher than it was actually in the report because new data was just updated after the report was released, where the obesity numbers unfortunately continue to climb. Ohio is in the top 15 states with population percentages of people who suffer from obesity. So mostly it's kind of southern states and then some of Appalachia. And what we've seen that obesity has skyrocketed, not just in Ohio, but in the last decade. So if you go back to this graph and you take a look at where labor force participation rate started to peak in 2010, we see the decline in labor force participation rate as obesity rates have spiked. Just to give you an idea, in 2012, no state had obesity around 35%, and now we have states topping 40% across the board. So just in a decade, we've seen obesity rates continue to spike. So how does this impact the workforce? So what the report does, it surveys a lot of different data, and we perform our own analysis. So the first thing is basically when people are obese, you're more likely to get sick. And so as a consequence, you miss work days. Workers who suffer from obesity are much more likely not to be at work because sometimes they'll have other illnesses that they need to be attended to. They don't feel well. And when they are at work, they're less productive. It may take them longer to do certain tasks. They may need to take more breaks. And again, this is because obesity is associated with other illnesses. And finally, what we see is that obesity contributes to people retiring earlier in their career. So that's the kind of the impact from an employer's perspective. If we're looking at it from the worker perspective, we start to get a little bit more depressing. Because we know that obesity is a disease that contributes to many other illnesses. We call them comorbidities. For example, heart disease, hypertension being obvious, diabetes being often another disease that is causal with obesity. We also see that workers with obesities are more subject to other acute injuries through like falls. Mental health illnesses and depression is also something that is also closely associated with obesity as well. So when workers have obesity, a lot of times they have a lot of other factors that can go back and contribute to the reasons they are not as productive at work. And so when people are sick and they miss work, what economists call is you miss out on human capital. That means the more work you miss out on, you miss getting your skills, you miss getting a promotion. We know that work experience is causal. That means the more you work, the higher your future wages are. And so for every day people with obesity start missing, they start piling up, and as a result, they don't get a promotion, they don't get a raise, or people who are paid hourly work simply just forego earnings. And so what we've seen that people suffering with obesity, other studies have found over about $100,000 in net present value is lost in lifetime earnings. And then they found out that women lose more earnings over lifetime compared to men. And probably not surprising given the first bullet point, people who suffer from obesity simply have a reduced life expectancy due to the different illnesses. So how does obesity impact Ohio's budget? Given the news and as Ohio continues to struggle with our budget for this next month, it might be of particular interest. So first of all, Ohio has workers' compensation paid for by businesses administered by the state. What we found is that workers' compensation costs increase because a lot more illnesses and injuries occur on the job. We also know that the increased cost of insurance to businesses, because businesses who provide insurance have to pay increased costs because obesity is costly to cover. Because we do not tax insurance, this reduces wages, other forms of taxable compensation, reducing taxable income to the state. There's also been a lot of studies taking a look at how the Medicaid program is impacted by obesity. Medicaid costs Ohio hundreds of millions of dollars annually, and that should just be due to obesity as well. And so not just obviously the Medicaid program in Ohio is billions of dollars, but because of obesity, estimates are it's hundreds of millions of dollars in Ohio and well over about $2 trillion nationally. So, and again, a different study said that basically almost 1/5 of Ohio's budget, about 18%, is due to obesity-related illnesses. And so this could be something along the lines of treating diabetes, treating hypertension, other forms of heart disease, all stemming with the comorbidities related to obesity. So very quickly about our paper, we want to look at the impact. Basically, are you more or less likely to be working if you suffer from obesity? We're using a national government data set. We're also basically looking at pool cross-sectional data as a fancy term, which means is we're looking at a data set over many different years. So it's not just a one-year snapshot. And if you take a look in our paper, you'll see our actual model specification for those who want to geek out on numbers and want to learn the math. And you can also see some of our robustness checks in the back. So what we found out is that obesity removes 32,000 Ohioans from employment. 32,000, if you think about it, is a great deal number of Ohioans. This means is if we were able to eliminate the disease of obesity, 32,000 more Ohioans who are not working today would be employed. So just to put it in context, it's about 15% of the total unemployed Ohioans in April Our unemployment rate would decline from 3.7% to 2.9%. So that is a sizable gap that would be erased and put us well above the national average in unemployment if we're able to bring these people back into the labor force and be able to bring them in jobs since they're no longer suffering from obesity. There's another measure that takes a look at the national average of basically number of employed people in the state to the total population. Ohio, again, trails the national average, but if we brought 32,000 more people back into employment, we'd surpass Oklahoma and Georgia, again, moving us closer up top. We also go through, we take a look and say, given the average amount of wages we expect to be paid, what would this do if people paid an income tax rate based on those average wages? It's about $20 million annually. And we expect that this number to continue to grow, again, because we expect them to remain in the workforce, get wages, so their taxable income would continue to increase. So I want to go through just a few policy recommendations that we make in the report. First is access to obesity-related care in line with evidence-based standards. This takes a look at treatment and prevention. There's a lot of different new research studies being going out there on how to use medical interventions, being able to use counseling to combat obesity. The key point is there's no single recommendation that we make. We want to be in line with kind of what the evidence shows. And we know that different people respond differently to different incentives. And so different standards of care may be more appropriate on a patient basis. Something that's unique to Ohio is that Ohio licensed nutritionists and dietitians. So if you go work out in a gym and you ask, how you can eat healthier, your gym instructor, your fitness trainer cannot give you dietary advice unless they have a waiver from Ohio's licensing standards. So we think that is unnecessary and prevents people from getting the nutrition advice that they need. Second of all, what we're starting to see now is a lot more utilization of obesity-related treatments in state healthcare and state employee healthcare plans. So in 2022, Ohio began to use obesity care medications, and so we can now study the results and see, has that resulted in fewer illnesses associated with obesity? Has this made workers more productive? And we're seeing other states start to move in that direction as well, compiling more evidence that researchers can use. So that's why we're saying look at best practices. Other states have conducted public awareness campaigns to try to combat obesity, to let people know, figure out ways that they can take care of themselves, see if those have been effective on a cost-effective basis. These are states such as Kentucky, Iowa, and other states listed in the report. And finally, what type of think tanker would I be if I didn't say, it's important we have a task force, to seriously take a look and make sure that we're keeping up to date. Because if there's one thing I want you to take away is that obesity is becoming a bigger and bigger problem, not just to Ohio employers, but we're seeing it being more costly to the state's budget. It's becoming more costly to employers who continue to cover health care. And so, we need to be on the path to solutions to bring Ohioans back to the workforce. So, thank you.
Mr. Ray, I know we was going for a question and answer, but I have a question is, you don't mention it at all, but we see it in our young people all the time. They spend so much time on the computer that the average weight of our young people has really gone up because they just don't exercise to the level they used to when people are growing up. And I don't make that point, but I see it. So as bad as it is, I worry about the future.
That's exactly right, Mr. Chairman. One of the things is there are multiple causes of obesity. There's no doubt that the transition for a more sedentary lifestyle, particularly for younger people on video games, people not doing as many youth supports, that's a cause. We've seen a big spike in obesity for COVID because we know that mental health sometimes contributes to the cause of obesity, and people that had mental health problems during the pandemic caused obesity rates to increase recently in many years. And that's why I think you take a look and say, we need many solutions, and part of it, could be get kids back to be more healthy. I battle with my kids, tell them to stay off their phones, but at least, they're involved in high school sports. But that is a problem that I think a lot of researchers are looking at. because not just overall obesity rates are increasing, but as you mentioned, childhood obesity is spiking as well.
You talk to employers, and you made a point about the Medicaid costs, I understand, but you talk to employers in the private sector, their healthcare costs, they go crazy on what obesity is cost, obesity in the back is cost to their healthcare costs.
Absolutely, we have. Tracy might have more recent data, but we've seen in the trillions of dollars overall cost nationally because of that very reason. And again, I want to mention that in context of the budget because if you're paying, so comp to an employer, how much I pay for an employee is not just wages, it's health insurance. And as you know, health insurance is becoming a bigger share of compensation. And so people are not seeing their wages going up because, healthcare costs and obesity is a major factor in why healthcare costs are going up for many employers. So.
Any other questions for Ray? Fantastic. Next, we'll welcome up Meredith Craig from the Ohio Chamber of Commerce.
Yeah, so I just have a few remarks. Obviously, Ray's presentation spoke a lot about the impact on employers, and we are seeing, healthcare costs for employers is the number one factor right now that they're dealing with in terms of costs. And so we recognize that as a chamber. We have released a blueprint here recently that shows a sense of well-being has a big impact on the workforce. And so as we attract employers like Intel, Amgen, Amazon, all of these employers, Google, that are starting to come to the state and adding jobs, we have to have a strong and healthy workforce. And so measures such as this, trying to incentivize and encourage employers to think about obesity as a chronic disease, right? This is a new avenue for us to explore in, but I think it's real. And so just from a chamber perspective, we want to be helpful in any of these conversations. We appreciate Ohio Life Sciences and Eli Lilly for gathering us all here today and for Ray's presentation. And just look forward to the conversations to come. We obviously know this is an issue. It's a real issue. Healthcare costs just keep soaring. And again, it's a factor of a lot of things. So with that, that's really all I have. I'm happy to take questions, but again, just appreciate this partnership.
Well, thank you, Meredith. Fantastic. And our last presenter today will be Tracy Sims from Eli Lilly.
Willa, thank you. We really appreciate the partnership with Ohio Life Sciences, and special thanks to Willa, who has worked very hard to create a venue for us to be able to come together this morning. I'd also like to thank Ray and his team at the Buckeye Institute. They have been remarkable partners and diligent in producing the analysis specific for the state of Ohio. Again, my name is Tracy Sims. I'm an executive director with corporate affairs at Eli Lilly and Company. In my role, I spend half my time doing health systems analytics and half my time doing real-world evidence research. I've been working in chronic diseases, diabetes, and obesity for over 30 years now. It is a pleasure to be here with you this morning. I appreciate your taking time to spend with us here. Obesity is a disease state that over the last 10 years especially has been recognized as a disease. There are over a dozen leading medical organizations, notably the American Medical Association, that recognize obesity as a serious multifactorial disease. The challenge, though, in these previous 10 years has been methodologies to not only diagnose the disease, but to treat it effectively. And us being here together this morning, we're really on the cusp of an absolute modernization of obesity care. The scientific understanding of the disease has grown significantly. The treatment methodologies that are available today across the board, be they preventative in nature, be they solely based on diet and exercise, sometimes referred to as intensive behavioral therapy, newer medications showing efficacy approaching that of bariatric surgery, and then for individuals who need this type of intervention, bariatric surgery itself. I think we all appreciate the medical impacts of the disease and its comorbid conditions. Some studies note as many as 200 comorbidities associated with obesity. From an economic standpoint, at the national level, as Ray has mentioned, the Milken Institute updates a study once every couple of years with total economic impacts in the U.S. approaching $1.5 trillion. There was a recent study published in the BMJ where they looked at the GDP impact of 161 countries. They looked at the GDP impact in 2019 and then 30 years out. Today, GDP impact at the country level ranges from 2 to 4%. And over the next couple of decades, will grow to 3 to 5%. You know, it's really easy to talk about the impact of the disease at a grand level, at a country level, at a state level. But I think it's really important to think about it at the individual level as well. Through my own research, I've had an opportunity to work directly with people who suffer from this disease. I've been able to lead or be a co-researcher in peer-reviewed work on the impact of the disease on individuals. And what we hear consistently is significant mental health issues associated with weight bias and weight stigma. We consistently hear issues around frustration when an individual with obesity goes to their healthcare professional and wants evidence-based care, but is unable to gain it from their healthcare professional. One reason might be the healthcare professional doesn't have the training or the confidence to make an evidence-based decision on care. Or the individual may have the ability to make that decision, but access to the type of care the individual needs is not available. We know that the disease significantly impacts well-being, just the ability to engage with somebody's children, with their parents, to be fully effective at their employer, as Ray has mentioned. Looking ahead, we believe that, one, we have to create an environment that reduces the bias and stigma around this disease. This is not all that different to decades ago when we had more effective treatments for mental health, depression as an example. But there was a bias, there was a stigma against the disease, which doesn't really exist today. It took time. But I think we can accelerate reducing bias and stigma for individuals with the disease. And I want to applaud leadership for the state of Ohio, because there are several methodologies through which they are exemplifying reducing weight bias and stigma. And one clearly is the state of Ohio providing access to anti-obesity medications for state employees. We believe that evidence-based care is going to help improve health outcomes, but in a sustainable methodology. Some individuals can improve their weight and the disease state's impact just through diet and exercise. But other individuals are going to need a therapy. They're going to need a medication. But that decision should be based on evidence. And for others, bariatric surgery might be indicated. But the state of Ohio, for its employees, has led in this regard. And that's important, and I think it should be grandly recognized. At the national level, we see similar leadership. Recently, the Federal Employees Health Benefits Program, the largest commercially insured pool of individuals in the United States, 9 million, now fully covers anti-obesity medications for that group of individuals. I know that we all enjoy a bumper sticker. And I think that as it relates to obesity and continuing to modernize care for the disease, for all the reasons we've talked about this morning, the impact on the labor force, the impact on Medicaid expenditures, the impact on individuals, I really think the bumper sticker is access parity. That's it. It's just access parity. When we think of obesity as a chronic disease, we're very familiar with other chronic diseases, diabetes, hypertension, cholesterol issues. These are all chronic diseases for which there is effective care that is reasonably well available. And as we think about continuing to advance obesity care in the state of Ohio, be that in the private sector, be that in Medicaid, it's just access parity. That's all it is. Helping the disease state of obesity have the similar access to care as other chronic diseases do. I think that the impact of the disease on individuals, the impact of the disease on the state's budget, the impact of the disease on the state's labor force warrants access parity. And then through Ray's very effective recommendations, studying what kind of outcomes are we gaining. I'm happy to answer any questions, but most importantly, I want to thank you all for joining us this morning and for your leadership in the great state of Ohio. Thank you.
Any questions for Tracy? Yeah, Senator Hackett. No, please.
And you haven't touched on, but Eli Lilly's been a tremendous leader in diabetes. We had, and as a good friend, we made a state rep that actually kind of slipped on his diabetes care, and it ended up killing him. And for years, I mean, my son's a type 1, and so Sue we knew Chris really well, and that Sue, my wife has a master's nurse, and she'd be on him on making sure he was following the scenarios. How do you handle, I mean, Sue will tell me at times, she studied everything there is about diabetes, and she'll see that, and I'm talking about type 1, not type 2, but on type 1, a lot of times she can tell if someone's not following their doctor type 1, they lose weight. Yeah, and so that's the issue. How does Eli Lilly deal with the obesity issue at the same time they're trying to counteract type 1 diabetes? How do they do that? My son has put weight on, but he's done a really good job of controlling his diabetes.
Yeah.
And so, but Chris was the opposite. Chris did a great job for years, but then he got divorced, and I think he wanted to get his weight down, and he put more emphasis on having lower weight and not following his diabetes.
Yeah.
So how do you handle that?
Mr. Chairman, thank you for your question. And first, I'd like to share, I've had type 1 diabetes for 44 years.
Wow.
So we could share stories. Yeah. Thank you. Yeah. That's a long story that we can chat about afterwards, but I want to congratulate you and your son for effectively managing a very complex disease state. You know, in diabetes, we talk about type 1 diabetes, and type 1 diabetes is the result of an autoimmune disease where the body actually destroys the cells in the pancreas that produce insulin. And for those of us with type 1 diabetes, we have to take insulin exogenously through an insulin pump or through injections, and then closely monitor our blood glucose, which today some can do with continuous glucose monitors, a remarkable advance in technology, or through finger sticks. It's a very complex disease, and the chairman is absolutely right. Individuals who are diagnosed with the disease have actually lost a significant amount of weight. And the reason for that is that the body has to find a fuel to run on. The body's preferred fuel is glucose, but absent insulin, to turn glucose into energy, the body has to look for another means of fuel. And its secondary means of fuel is fat. And the body will burn fat to try to develop energy, but a negative output of that is called ketones. And people with type 1 diabetes who are not in good control or haven't been diagnosed develop something called ketoacidosis, and that can kill you in pretty short order. One indicator of individuals who have been well controlled with type 1 diabetes is they'll have a normal weight. And our ability to effectively manage type 1 diabetes puts people with type 1 diabetes at risk of developing excess weight. Type 2 diabetes is a very different disease. Type 2 diabetes affects 95% plus of individuals with diabetes. It is very much of a metabolic disease state for which we have a wide range of therapies. But there's an interesting intersection between type 2 diabetes and obesity, and this may be where you are headed. About 80% of people who have type 2 diabetes also have obesity. And this brings me back to my earlier comment that we're together at a time in a major shift in care for these metabolic diseases. When we look at the literature, the first recommendations, there's two for the treatment of type 2 diabetes. The first recommendation is reducing body weight by as much as 15%. Reducing body weight reduces insulin resistance and hopefully helps individuals better control their type 2 diabetes. So that's one, reduce body weight. Two is aggressive blood glucose control as early as possible. And these two things together give benefit through the course of the disease. I think the theme through all of this is that we recognize the detrimental impact of obesity as a disease unto itself, but also in the intersectional space with diseases like type 2 diabetes, where again, the literature says if we can reduce weight by 10, 15%, we're going to put a person with type 2 diabetes or a person with obesity in a much healthier state. Here, if I could just extend for a moment, we will release data from a survey of over 1,000 individuals with obesity through a poster, medical conference poster in the coming months. And I think there's an interesting trio of achievements that are present today. The first is the medical literature saying 10, 15% reduction in weight confers significant improvement in health. So that's one. Two is we are at a time with new therapies where achieving 10, 15, 20% reduction in weight is fully achievable. That has not been achievable in the past. Today, it is achievable. That's the second. But the third component of the triangle is this, the findings of this survey I was mentioning. And when you ask people with obesity, what is a weight reduction percentage that is going to make you feel healthier, that is going to make you feel enabled to engage in your job or in your life activities at a level that you would like, what you get returned is a range of about 14 to 17%. So you pause for a second, you say the literature says 15%. It might be different for different individuals, but about 15%. That's the literature. The therapies, eminently capable to do that. And then what do people with the disease state want? 14 to 17%. And the only barrier between those three items is access parity. So again, I want to highlight Ohio's leadership. There are other areas for ongoing modernization of care across the country and here in the great state of Ohio, in the private sector and in Medicaid. But I think your question is a very important one and one that we need to continue to talk about and closely study and share the findings of. So hope that helps. Thank you for your question. Okay. Thank you.
Perfect. Thank you so much. All right, that concludes our program. Thank you again to all of our speakers, to Eli Lilly, to the Buckeye Institute, and to Paul Worth and Associates for recording this event. That's all. Please feel free to grab some breakfast and network.
Thank you.